everyone. Welcome back from the short break. I have the pleasure to introduce the next plenary session, which is on the state of service delivery and health-seeking behaviors. I would like to therefore invite our facilitators of the session, Gloria Seruwagi, who is the Research Uptake Manager at Baobab Research Program Consortium at Population Council, and David Mbuvi, the Gender and Protection Coordinator, Humanitarian Early Recovery and Development Program, the HARD project at the Canadian Greensburg. Gloria and David, over to you. Thanks.
Thank you, Christine. Good morning, good afternoon, everybody, wherever you are. Thank you very much for joining this symposium. I'd just like to check that I am audible. Can you all hear and see me, hopefully, because my video is on. Can I just get some?
I can hear you and see you.
Yes, we can hear you clearly.
That's great. So welcome again to this plenary session. I believe having had a truly inspirational keynote session and understood what the data is telling us and got some insights from the empirical work that has been done on this topic, and also having looked at barriers to access, it's only fair that we move now to see what the state of service delivery is and help seeking behaviors. So this session is on exactly that. And we have a great lineup of speakers from different organizations, some of whom you see on the screen that's being shared. And a very fast presentation will be given by, I believe it's a consortium of colleagues from Women's Refugee Commission. That is Katherine Gambir, who will kickstart off the presentation, and she will be co-presenting with her colleagues from Reproductive Health Uganda, Makerere University, School of Public Health. So I'd like to request Katherine to just get ready to talk in the next few minutes. But before that, to request that please feel free to share your questions, observations, and anything you might want to communicate with us in the course of this session in the chat. We are monitoring the chat and we are taking down all the questions. We'll be doing that. So please feel free to engage, and let's make this very productive and very interactive as well. So as I said, Katherine Gambir will start the presentation. She will be co-presenting with Brenda Tideru from Reproductive Health Uganda, alongside Ronald Ssenyonga from Makerere University, and Dr. Christine Nalwaada, also from Makerere University, School of Public Health. So without much ado, I'd like to hand over to Katherine. I hope you're on, Katherine, and you can hear us, and please, you can start. Thank you.
Thank you so much, Gloria, and thanks to all of the organizers for the opportunity to share our research. Hello, everyone. My name is Katherine Gambir. My pronouns are she, her. In efforts to make the presentation a bit more engaging, I will serve as the moderator for this presentation, which you will hear findings from our baseline study that is part of an impact evaluation of a community-based sexual and gender-based violence prevention and response intervention. Then our panelists will share their insights and recommendations for future SGBV research and programming among adolescent refugee boys. So first, I will provide very brief background on the project. So in 2022-23, the Women's Refugee Commission, or WRC, and its partner in Uganda, Reproductive Health Uganda, commenced implementation of an integrated sexual and gender-based violence response and gender transformative prevention intervention for refugees and adjacent host community members in Adjumani district, Uganda, called the Community Cares Project. So Community Cares trained village health technicians to identify adult and adolescent survivors of sexual violence and refer them to the nearest health facility and other referral services, and train them to deliver gender transformative SGBV prevention activities. Prior to implementation of Community Cares, Makerere University School of Public Health conducted a baseline study to document the status of the project indicators among community members in Adjumani. So we could compare baseline results to end-line results after the intervention was implemented. This presentation will focus on findings among the adolescent refugee participants only. So we should be on the methods slide. Awesome, thank you so much. So this baseline study is part of a mixed methods quasi-experimental study design to evaluate rigorously the effectiveness, acceptability, and safety of training village health technicians to, one, identify sexual violence survivors, and two, refer them to health facilities or other referral services, and three, to train the village health workers to implement gender transformative awareness raising sessions in the community. So how did we do this? How did we measure the effectiveness of the intervention? Well, in our baseline study, we implemented a knowledge, attitudes, and practices survey, which was administered to over 1,500 community members, including over 200 refugee adolescent girls and over 300 refugee adolescent boys. We also facilitated participatory focus group discussions with 238 community members, including 82 refugee adolescent boys and 72 refugee adolescent girls. And finally, we conducted 14 key informant interviews with community leaders, service providers, village health technicians, and members of the project's community advisory board. Next slide, please. Thank you. So now it's my pleasure to pass the mic to my colleagues at Makerere University School of Public Health to share with all of you what we learned from the baseline study. Over to you, Ronald. And next slide, please. Ronald is in transit, so it looks like he has just lost connection. So I'm pleased to then pass the mic to Dr. Christine Nalwaada.
Okay, thank you, everyone. I just want to add my voice to Catherine's for giving us this opportunity to share our findings with you during this symposium. So what did we find? We found that in terms of service barriers faced by these adolescent boys, they had first of all, they were not very different from the girls, but we are concentrating on the boys. So you'll find that some of the issues that they mentioned included corruption, delay of services at the points of service delivery, and the other barrier was the communication barrier, where they mentioned a language barrier between those who are seeking the services and then the service providers. But some of the participants also mentioned the distance they are moving from their homes to the delivery points or the service delivery points, they expressed that these were long distances. So at times they barred them from seeking these services. However, we also noted that some of them didn't actually know, as you could see that you would ask a question and there is no response. But these are the main barriers that were able to, that were mentioned by most of these adolescent boys. Next, please.
Thank you so much, Dr. Christine. Since Ronald is not on the call, I'm happy to take his slide. So if we just go back to the first slide on participant characteristics, just to give you all an overview of who was in our sample. 529 refugee adolescents participated in this baseline study. And adolescent boys 13 to 19 years constituted 61.8% of the sample, so the majority of the sample, compared to 38.2% of adolescent girls. And almost half of the adolescents were in the age range of 15 to 17 years. The majority of the adolescent refugees who participated in the baseline study were literate, and less than 10% reported living with a disability. And finally, almost all of the adolescents, almost 99%, reported South Sudanese nationality. Next slide, please. So when we asked participants whether or not they've heard the term sexual violence, overall, adolescent girls demonstrated greater awareness of sexual violence compared to adolescent boys. However, there were differences among the age groups once we disaggregated by sex and age groups. And we found that adolescent boys, 13 to 14 years, actually demonstrated the least amount of awareness about sexual violence. And this increased with age, or awareness increased with age. Next slide, please. Dr. Christine, would you like to add anything from this slide?
Yes, yes. In terms of sexual violence knowledge, we found that the boys across all ages demonstrated some awareness and knowledge about sexual violence in their communities. And we found that the boys mostly cited scenarios of sexual assault and rape that was done by the men against women, and also the girls. However, the boys were also able to tell us that even the boys were experiencing this sexual violence, unlike the girls who mainly pointed to the girls. So the sexual violence actually included things like rape, defilement, that were caused by the boys forcing girls into sex, as well as touching their private parts, and sometimes their behind. So what came out from this discussion, that we were able to, the boys were able to tell us that actually sexual violence happened against the boys, but also the girls. Next, please.
Great, thank you, Dr. Christine. So we also asked participants to share consequences of sexual violence. And the graph here shows the responses disaggregated by sex, the girls in yellow and the adolescent boy responses in green. So almost all of the adolescents mentioned at least one consequence of sexual violence. Approximately 60% of adolescent girls mentioned a health consequence compared to 54% of adolescent boys. More adolescent boys compared to girls mentioned a mental health consequence. And overall, boys mentioned slightly fewer consequences. So in terms of service availability for survivors, awareness of services available for survivors in their community was extremely low across adolescent groups. Only one adolescent girl and 6 adolescent boys reported knowledge of services available in their community for survivors. However, Christine will elaborate on these findings in the next slide. Over to you, Dr. Christine.
Thank you, Catherine. Now, in terms of service availability for these survivors, when we asked them where they seek for the services, when they experienced the gender-based violence, we received responses like they go to police station, they also go to the office of the Prime Minister in that district where we conducted the study. The office of the Prime Minister is in charge of the refugee welfare. So they reported that they also go to that office. They also reported that they go to the chairman. Now, in this context, a chairman, this is the village leader of the village, the nomenclature we use, that person who leads the executive that manages the villages is the one that referred to as the chairman. And so these adolescents mentioned that they go to this chairperson, and some of them also mentioned that they go and seek care and services to the health centers. And in this area, there is that particular health center that Airo, where they would go for the services. Next, please. Next slide, please. Yes, again, we looked at the service. I think I mentioned about this. The barriers that they faced in seeking care or seeking services. I think I mentioned the issues of corruption, issues of delay in the services, issues of language barrier. As you heard Katherine present, with majority of these adolescents were from South Sudan. So the language barrier is a big issue of from the service providers, because service provision is done, service provision is for both the host communities and the refugee communities. And you find that those who work in the host, those who work in these facilities are mainly from Uganda. So the issue of language is a big one. And then the distance, as I had earlier mentioned. These were the main barriers faced by these adolescents.
Thank you so much, Dr. Christine. In interest of time, I'm going to please ask to move to the next slide. Next slide, please. Thank you. So I'd like to introduce our other colleague who's co-presenting with us, Brenda Tideru from Reproductive Health Uganda. And Reproductive Health Uganda is the lead implementer for the Community Cares Project in Adjumani. Brenda, can you please share with us, how did your team use the findings from this baseline study to inform the design of the Community Cares project? Particularly, how did these findings inform the ways that you engaged with adolescent boys on sexual and gender-based violence prevention and response?
Thank you so much.
Brenda, it's a bit hard to hear you. Can you speak louder into your mic?
Hello, is this better now?
Yes, it's a bit better. Thank you. Go ahead.
Right. As a reproductive health Uganda, case workers and persons that deal with the community and explore and guide them on how.
Brenda, sorry, I can't hear you. I'm not sure if others can. It's very faint.
Hello.
Brenda? Yes, Brenda, if you could, this is Gloria, the facilitator for the session. I'm just, I think, adding my voice to Catherine's, that if you could kindly speak into the mic a bit louder, we'll be very happy to hear you better. Thank you.
All right. Can you all hear me better now?
That's better, Brenda. Thank you.
All right. I was saying earlier, as Reproductive Health Uganda, during the project implementation, we found it important to train health workers, case workers, and all persons that handle GBV cases in the implementing site on how they could work with male adolescent survivors. And this was to solve issues related to unskilled personnel. And as most people reported challenges in confidentiality, which created mostly unsafety for male survivors. Then we also added the community awareness and to inform the community that sexual violence can actually happen to anyone. And then we also targeted how to reach these adolescents. And then we are currently having community awareness dialogue and interactions with them in places such as entertainment centers and where we can easily reach them, so that we provide them with information on where they can seek care from, and also let them know that they can experience sexual violence despite them being males or adolescent boys. Yes. And then next on the recommendations we would have, first and foremost, for any person who is interested in implementing GBV programming among refugee boys, we need to understand that one of the challenges we have is that we have issues with reaching out to the boys who are out of school. The community where we're implementing from has a lot of boys that are out of school. They stop studying at around 8 years. So there's always a challenge of reaching out to those boys. And then secondly, what would work very well is what we call a community advisory board, which has a team of stakeholders that provide feedback on what is happening in the community. So these ensure that adolescent boys' intersecting needs and priorities are central in any programming. So they will always give feedback on how best we can be able to engage these adolescent boys in programming. And then lastly, it's always very key to involve community stakeholders in these meetings. These are crucial, they nurture connections, and then they promote a sense of ownership and advocacy. And this eventually promotes access of SGBV interventions in the communities. Thank you so much. I hope I was more audible than the beginning.
Yes, you are, Catherine. Are you still? Do you still have more to say?
Well, I think we may be over time. Thank you so much.
Yes, I think we are running a little over time. Thank you so much, Katherine, Brenda, Dr. Christine. Very interesting presentation there, innovative model, this community care project, and also great participatory approach to presenting your findings. And now it is my privilege to introduce my co-facilitator, David Mbuvi, to take us to the next presenter. David, over to you. Thank you. David, are you there? I don't know if you can hear me. Are you able to take us on to the next presentation? Okay, David might be off. I think he might have dropped off the call. I do not see him in the participants list, but he was on earlier. So I will then take on.
Thank you so much, Gloria.
Is that you?
Thank you so much, Gloria, for that great first session.
David,
Yes.
we can't hear you, and your background seems to be noisy.
There's some noise on the background. My background. Sorry for that. And now?
David, it's perfect. Thank you. Yes, I can hear you.
Thank you so much. Thank you so much. My name is David Mbuvi. I work for the Canadian Food Grains Bank, and happy to present to us our second presenter from the Railways organization in Tanzania. We have Mary Gatama, who is the project manager, who will be sharing with us on responding to sexual abuse of boys living and working on the streets in Tanzania. And she will also be presenting together with Mary Mushi, who is the safeguarding and technical lead in that our project. So without much ado, allow me to share the screen and invite Mary to pick it up from me. Thank you, Mary.
Thank you, David, and thank you for the introduction. As David said, my name is Mary Gatama. I work for Railway Children Africa in Tanzania. I'm the program manager. So we are happy to be part of this symposium and to share our work, specifically in supporting sexual abuse survivors, boys, street-connected boys and girls. Next slide, please. So just a bit of Railway Children Africa. Railway Children Africa, we work in Tanzania. We work to support street-connected children and youth. And we are implementing in 2 cities, that is Mwanza and Dar es Salaam. And also we are providing technical support to other organizations working with street-connected children in Tanzania. So just to give you a bit of context in what we'll be talking about is that in the last 2 years, Railway Children Africa has supported 705 street-connected children. And of that, we've received and supported 75 child protection cases. And 73% were boys, while the rest were girls. And in regards to the nature of the cases, the majority of the cases received was sexual abuse. As you can see on the screen, 63% were actually sexual abuse cases, and 36 of these were boys. So my colleague, Mary Mushi, will go into the details of how we have supported sexual abuse survivors and what has been our learning and our experience through that. Thank you, Mary, and good morning, everyone. So next slide, please. So picking up from my colleague, Mary, let me start off sharing with you in terms of what we see have been the barriers in terms of
and the young people that are living and working on the streets. So we have the barriers that are more related to the survivors, and others barriers that are related to service providers and the community. So to start with the barriers with the survivors I think we share with the global barriers that we all know about. But one thing I wanted to highlight with the group of children and young people we work with in street situation, what is more common and has been the barrier, it's the normalization of abuse. So these children and young people have either left home because they have experienced the abuse, and when they're on the street, they continue to experience abuse. So to the extent that even when they're sexually abused, for example, they may see that as not abuse, or it makes it, or they don't find it a reason to report and seek help. And also there's that, the view around the street connected children and young people who most of the time, because of their experience, they also have some challenging and difficult behavior. And most of the time they are found in conflict with the law and sometimes involved in police roundup. So which this then has now led for them to not trust the service providers. And also they have the fear of unknown, not knowing what will happen in case they report. So what we have tried as an organization to incorporate into our programs to try to break these barriers have included in establishing trust and safety. And by this, we ensure every child and young person we work with, and more especially the survivors, have a specified caseworker who is working with them. So this caseworker will be there with them, listening, supporting them throughout, accompanying them to receive various services, for example. So we also provide trainings, and the trainings are aiming into supporting the children and young people and the survivors to understanding their rights, also understanding the different abuse they could experience, how and where to report this abuse, and how to seek help. We also encourage peer-to-peer support on the streets, and we have seen this have really improved, where we have several cases that have been reported by other children and young people who have observed or seen others being abused, or they've heard about it. So, but we have field-based safeguarding reviews where we have our caseworker and sometimes the child protection officer goes to the street and deliberately speak with the children, trying to find out if they have experienced the abuse or if they have had others who have experienced the abuse. And we have found these are useful. So next slide, please. So in this next slide, I'll be talking more in terms of the barriers that are more related to the community and service provider. And here service provider also include our staff and frontline workers. So it's the biggest barrier here, it's the attitude towards street connected children, where they're seen as a problem, they're troublemakers. So sometimes their issues are not taken so seriously, and sometimes they are not listened to. And also because of their difficult behavior, we tend to be more drawn to some of the difficult behavior they're displaying, and we try to find a way to resolve it, and sometimes forget some of the underlying causes, which could be the abuse. So what we have tried to incorporate into our programs in terms of breaking this barrier with the community and other service provider, we have come to learn and realize relationship and networking with other stakeholders and service providers is very key. So we work very collaboratively, for example, with social welfare officers, with the police, with justice actors, with health providers, and we have different engagement and advocacy. This is based on individual cases, but also we have ongoing quarterly meetings where we meet and discuss some of the challenges that we have seen, some of the learning we have seen with our safeguarding and child protection cases that we have reported. So, and training is also to empower our own frontline staff and also with social welfare officers and the larger community into understanding about sexual abuse, and especially to male child, how to respond, how to prioritize early rescue, and how it's important to support and facilitate the access to justice, which has really given courage to some of the children and young people when they see when they report the victims action is taken, that have encouraged them to report more. So after speaking with on these barriers, so next slide, please. So in the next slide, I will be taking you through more in terms of internally our reporting mechanism and how we respond to services. Next slide, please. Okay, so I think we have some delays with the internet, maybe the next slide coming through. So another thing that I wanted to talk about, it's our reporting procedure. So what we have tried to strengthen as an organization is our reporting procedure. So we have a safeguarding policy and a procedure that provide step-by-step guidance to our staff in terms of how to deal and how to work when they receive sexual abuse cases, for example. This procedure also clearly give a list of criteria, what cases should be reported, and how to respond if it's either beneficiary or not a beneficiary that we are already working with. And the procedure also guides in terms of who to report to, where to seek support. And these have really provided a framework to our staff, and our staff have found it very, very helpful because it releases that pressure of handling some of complex safeguarding and child protection cases as abuse. So these have really been helpful. So what we really also encourage and prioritize in our reporting procedure, it's reporting to authorities, including the social welfare officers, the police, and other local authorities. So the reporting for us is not only to meet the legal requirement, but the importance of us reporting is the beginning of coordinating the services and support to these survivors. So then this leads us to our next slide, which is more in terms of what, as Railway Children Africa, what is our response and how we support the survivors. So when we receive the cases, our first point is to report to authorities. As I said, there's police and social welfare officer. At the police, we are given a PF3 form, a police form. And in this form, it gives us access to accompany the survivor to a health facility, and most these are government health facility. This form is again filled by medical practitioner and is taken back to the police, and in most cases, this form is used in court as evidence. So we work with the social welfare officers in recommending where safe the children or the survivor could be placed as their cases are ongoing and as we are looking for what are the next steps. We also work with justice actors to see how these children can be able to access justice. So sometimes when the cases are reported to the police, the children are required to report, and in this case, we accompany them in this process. We develop child protection plans, but what we look into our child protection plan is not only the immediate needs, it's also looking at the long-term needs of these survivors. So for example, if a child wants to be reunified back with their family, we do that. We reunify them with their families when we feel it's safe for them to be reunified. And we continue to provide the individualized case management based on their needs and provision of therapeutic support. And the caseworker continues to do follow-up of the case and continue to provide services as it will be needed. But we are very keen to make referral where we don't have the capacity to. So to sum up what I've just spoken, may I share with you a case study of our hero Zahoro, so that you can get a picture of what I was saying in a real sense. So Zahoro is a 15-year-old boy now. He ended up on the street when he was 13 years old. And the reason he ended up on the street, this is after his mother became very sick and he lacked care at home. While he was on the street, he met with a man who promised to offer him a job and a place to stay. Unfortunately, as he was working for this man, he was subjected to sexual abuse by this man who had employed him. And he was also threatened death. So it took a while for Zahoro to be able to gather his strength and report what was happening. Luckily, one day he got courageous and he reported his concern to one of the Railway Children Africa, a former beneficiary. This beneficiary has a business near to a ferry where it's close to a beach where most of the street connected children go there for shower and all that. So when this report came to this former RCA beneficiary, together with Zahoro, they reported to our office, and the project manager and child protection officer, when they received this case, the first step was to assign the case to a specific caseworker who would make follow-up for this case. So from here, then the caseworker accompanied the child to the police to get a PF3 form and a referral to a medical hospital, to a health facility for the child to get treatment and checkup. And the medical results confirmed that Zahoro had experienced this serious sexual abuse. So while we continued at that moment where we were wondering where we should take Zahoro, he requested he wanted to be reunified with his family. So our caseworker worked very closely with the social welfare officer, and they conducted the assessment, and when it was safe, he was reunified back home with his family. Back to the family, it was really difficult for the family finding out what had happened to Zahoro. So our RCA caseworker had to work very closely with the family in providing some emotional support to the family. While the family work was ongoing, also the police case was ongoing. The case was in court at this moment. So there were times that Zahoro needed to attend to give testimony, and our caseworker, with support from child protection officer, they had to accompany him for these court sessions. In the end, the abuser was found guilty, and he was convicted to 30 years in prison. At this time, I'm really, really happy to report that Zahoro is back home with his family. He's enrolled in vocational training, and as RCA continued to be involved in providing psychosocial support to aid their healing. So I hope you got a bit of a picture of what is happening. So I will hand again over to my colleague Mary to share some of the challenges that we have encountered, and we are looking forward to learn more. Karibu, Mary.
Thank you, Mary. Just to sum up our presentation.
Okay, Mary, sorry to interject, but could you please do that in less than a minute, if possible? We are running over time, okay?
Yeah, sure. I'll just highlight maybe the main ones. So one of the main gaps we've seen is the lack of specialized services, specifically therapeutic support. So as much as our staff are trained, but in areas that we are reunifying the children, we don't have those services. And when they're available, they are quite expensive. And then also the balance between working with a child who is a sexual abuse survivor, while at the same time they are a perpetrator. So trying to support them and also help them to be accountable. In terms of contextual safeguarding, this is something that we are looking at. So a case in point, we had a case where sexual abuse cases were happening in a certain bus terminal, and we had to look at what's the context, what's happening in the environment, how can we use in the stakeholders in that area to support the safety of the children. And lastly, the gap in systems and policies. Like when is, for example, PF3, that's an issue that we've continually encountered. When is it permissible or not permissible in court, and how does that affect the outcomes in terms of accessing justice for the survivors? So those are some of the main challenges we've seen. Thank you for listening to us. Yeah, and we look forward to engaging further and learning from each other. Thank you.
Thank you so much, Mary, and my sincere apologies to the mix-up in the slides, but I believe we were able to learn a case in Tanzania on how best, and they have been able to apply some of the lessons and providing us with some lessons to the questions that we have been raising since we started this session. Allow me to invite Gloria to help us get some questions and some feedback to this section. Gloria, please.
Thank you, David. And once again, thank you, presenters, Mary Gatama and Mary Mushi from Rare Child Africa. And thank you to the very engaged audience. We are taking note of the questions, the reflections, and takeaway points that are being sent in the chat, and we will continue to collect them and respond to them as as we go along. Unfortunately, our time is really fast spent. We should have used 15 minutes, which was 12:15, and it is now 12:16. So I'm going to request that if you have a really burning question, we could take about 2 and then close this session. But in the meantime, can I request Mary and Mary Mushi and Mary Gatama to please have a look in the chat and see if you could respond to some of the issues that I imagine in the chat room. But thank you so much to the audience for sending those. So if there is anyone with a really burning question for our presenters, please, if you could raise your hand, and then we should be able to get this Q&A session going. Thank you. Anyone with a question or a reflection or an observation that they would like to share with us all? Okay. I do not see any hand, but if you are there and I can't see you, feel free to unmute and ask your question. But I do not see any. Although there were lots and lots of questions around managing, the security of caseworkers. Some of the documents are being asked for by the audience, by the delegates of this symposium participants, and I believe the conference organizers, these documents will be shared along the way. I think overall, if we don't have a question, what I could say is what we've just heard, experiences from Tanzania on the state of service delivery and the state of health-seeking behavior. Of course, they confirm what we saw in earlier presentations on the data emerging around the magnitude, the patterns, and really the key issues surrounding our topic of discussion today. And then this is especially in humanitarian settings, but also in these fragile and complex scenarios. Mary, I see your hand is up, and I'll allow you to speak in a bit. And I think it also that the presentations also confirm the barriers that we saw, the systemic barriers, conceptual barriers, social cultural barriers, and then things around integration of some of these systems responding, as well as the innovative services that are out there. So I'll let Mary say something. Her hand was up. You might want to respond to some of the questions, maybe 1 or 2 in the chat, and then we will take it from there. Mary, please.
Okay, thank you, Gloria. I think it's just response to some of the questions that we have seen from the chat. So there was a question around how do we ensure the safety of our case workers, so the staff. So we have risk assessment with mitigation in each of our project area. So, and each of the team has put some mitigation to ensure not only the project and the beneficiary are safe, but even the staff are safe. And we encourage our staff in most cases in street situation to go work in pairs. and the line manager is always informed. And if we are going to a place where we think it's more really risky, we involve the government officials like the police or the social welfare officers. So that is how we ensure safety. And I think there was another question around, do government caseworkers, are they trained? Yeah.
Are they working at the family level?
Are they working at the family level? Not as much. So the government social welfare officers really help facilitate the process, and we work with them hand in hand. So, but they don't work directly with the family unless we either support them because of, I think, resources on their hand. So we have to support them to be able to be visiting the families. But in most cases, we work with and we facilitate the resources. And this is in some cases where we think we really need as government social welfare officers to be involved.
Yeah, and maybe just there are quite a number of questions that will be interesting to respond. So I hope there'll be a chance for us to connect with people that have asked those questions so we can respond.
Yes, I believe there will be, and the organizers will see to that. So we'll try to answer some of these. Christine and Katherine and Brenda, I wonder if you have anything burning that you'd like to respond to as well in regards to your presentation and what people are saying in the chat. So if there are any last reflections you want to make as the first presenter. Anything, Christine, Dr. Christine and Katherine, as well as Brenda? Okay, and then I will hand briefly back to David, who will then hand back to Christine of UNFPA to take forward. David, my colleague, my co-facilitator, do you have anything that you'd like to say? Over to you. Thank you.
Not really, but in the interest of time, just to encourage all of us to connect with the presenters so that we can get some in-depth information on these case studies. And I believe they provide a lot of evidence in terms of how best can we do this, what are some of the challenges that we are facing, and we can get collectively that peer learning on the best practices that we can be able to adopt and contextualize within our systems and within our programming space. And once more, thank you very much for creating time to be here and looking forward to further discussion. Thank you, Gloria, for being there and the support therein. And so we take it back to Christine and George to take us to the next session. Thank you very much for the opportunity to host and to co-host this session. Thank you.
Thank you so much, Gloria and David, for moderating the session, and thanks to the speakers from Women Refugee Commission, together with Makerere University School of Public Health, Reproductive Health Uganda, and Railways Children Africa. And I can see that a number of questions are on the chat, and I hope you'll continue to address those questions in the chat.